Thursday, March 23rd. So pursuant to the Illinois Open Meetings Act, meetings held remotely will require roll call votes for all action items. And to streamline this, we're combining our action items into one combined motion. So only one roll call vote will be needed during the meeting. I'm going to go ahead and ask to call the meeting to order and ask Madam Secretary to please call the roll.
Director Garza?
Present.
Director Story?
Present.
And Chair Kim?
Present.
And for the record, those directors also present. Director Sorrell?
Present.
You have a quorum.
Great, thank you. Just a note, our next regular meeting of the Quality and Patient Safety Committee is on Thursday, April 20th at 10:30. I'm going to ask Madam Secretary if there's anyone registered to provide virtual oral testimony or have submitted any written testimony to be included in the record today.
We did not receive any registrations, nor did we receive any written testimony.
Okay, thank you. We're going to go on to item number 3. These are informational items only, so there'll be no action needed for these. We'll start with the HRO dashboard. Dr. Makaitis, Chief Quality Officer, can you please provide us with an update?
Of course. Good morning, everyone. And so we're going to do a little bit additional information this time around. I wanted to provide a bit of background as to where we're going with the HRO committees. So you see here where we've landed on the current structure. So we have our steering committee and then those 6 work groups, and that cadence of reporting is going to continue as we've had, and I believe our clinical outcomes team is going to give their first report. That is a new committee. We've worked to combine our mortality with a few of the measures in process of care, which was one of the old groups, and then kind of right place a few of the other, we had some readmission metrics in there as well as some throughput focused metrics. And then throughput has also come in under this process. The system that we're going to talk about lends itself very well to the work around throughput as well. So you can see there the identified leaders and executive sponsors. If we go to the next slide, please. So what we're building here is in a way, it's called catchball. So the plan here will be that the top down, coming from steering committees, work groups to subgroups, is the what, right? We drive strategy and areas of focus from the steering committee on out to the frontline teams. And then the catchball, the coming back up, we'll review the tool that we're going to use, but that is kind of the feedback. It's offering where we're seeing wins, but then also where maybe we're experiencing some pain points and where leadership may need to help kind of remove some roadblocks. Next slide. And this is to demonstrate the kind of right altituding of the metrics. So at HRO steering on up to this committee, we focus on kind of those 30,000 foot measures, right? Those CLABSI rates, the SIRs, overall readmission rates, rate the hospital, for example. So here's an example specific to CLABSIs. As we move closer to the front lines, we start kind of drilling into things that contribute to the rate. So when we get to the subgroup level, we start focusing on things like line days. And as we reach the front lines, we focus in on even more bite-size tactics and measures. So in this case, we would look at things like bundle compliance, things that the frontline team can really put their hands on and move the needle on in real time. So things that are helpful. Giving them an SIR isn't very helpful at the frontline team for them to try to move the needle on. Next slide. So here's our current state. Our work group teams have done a lot of work in bringing in subgroups and forming the work to really drive to the front lines. So you see at the very top there's our committee with this committee with HQIPs and the HRO steering committee, the 6 work groups across the top, and then the subgroups that those teams have identified to really get to the front lines and start moving the needle on this work. Next slide. So I can zoom out. Thank you. So this is the tool that I was referring to earlier. It's an A3, which for those who may not be familiar with some of the lean tools, an A3 really at the end of the day is just a paper size. It's the biggest piece of paper that Toyota could fit through a fax machine when they were developing this methodology. And as a tool, it's really used as a communication tool. It's allows us to tell a story, and in this case, to manage the work as well. So down the left side, this is kind of the way to read the A3. You start down the left side, that tells the story of where we've been successful, where we've struggled, and then our rationale for next steps. And then at the top, kind of more on the right-hand side, we have goals, actions and tactics, and then deployment leaders. And at the rightmost section, that's a Gantt chart that helps us kind of deselect and focus in on things 2 or 3 at a time to make sure that we're not overcommitting and losing focus where we're trying to really improve. Next slide. So we're going to get into the data that we've been used to seeing, but I'm also going to start sharing a little bit of the tactics that are behind the data that we're currently kind of at nearly the end of the build phase right now. So we see on 30-day readmissions, again, this is for Stroger. And we've dropped now to 8.56%, a nice downward trend over the last 3 months. We are all in for 30-day unplanned all-cause readmission at 9.73, which meets our stretch goal. Some contributing factors this month were general medicine improving from 13 to 7%. 7-day all-cause remains very low at single digits, just under 3% readmissions. Heart failure did increase, but we're still doing better than our comparison group. We were at 16%, so our comparison group is at 18%. Next slide. So this is the full A3. I'm just gonna, for the next data slides, I'm just gonna drill in on the right-hand side, but this is kind of give you a sense of, what is really in there, right? So we tell the story on the left, and then we're gonna focus in kind of on the right. So we're looking at things like reorganizing our transitions of care team to risk stratify and look at by unit and condition, so we have consistent teams working together. And then again, really kind of getting into the risk stratification to make sure that we are right placing those resources to people who need them most. And then if we move down a little bit, focusing in on some of our bigger opportunities that are disease specific. So you see renal failure there, a few tactics on where the team is wanting to focus. CHF continues to be an area of focus, and we're actually raising the bar a little bit. We're going to start looking at excess days and not just overall readmission. So excess days of acute care is another way of measuring. It's a little bit tougher. It doesn't just look at readmissions. It looks at any utilization over the next 30 days after a discharge. So we return to ED, observations, those don't count as readmissions, but it's still additional utilization that's with robust transition planning patients may not need. And then finally oncology, which if I remember from last month, I believe we had increased from 8 to 22%. So a big area of focus there. Next slide. So moving on to case mix. So this is medical. We're relatively flat, 1.24 to 1.23, sorry. And then if we go to the next slide, that's surgical. We did see a nice increase. That's been where most of the focus has been. We've increased from 3.1 to 3.23, well above target and stretch. If we go to the next slide, we can show a little bit of, there we go. So this is really kind of the right side of where we're going to be focusing. So Dr. Keene for surgery has really engaged and identified leaders for subcommittees where we're going to really drill in and see those opportunities, the kind of the 2 or 3 things that each of those specialties in surgery really have opportunities to improve in terms of really getting credit for just how sick some of the patients are that they take care of. And then similar for medical. And then we're going to add a little bit to the work and focus in on mortality indices, making sure that we're capturing not just on the documentation side, but initiating mortality reviews to look for any care opportunities as well. Next slide. So this is our rate the hospital. I'm going to show this 2 ways. So this is by discharge date. And if we go to the next slide, this is by receive date. So typically on reported data, receive date is what they look for. However, now as we're implementing a lot of this work for all the things that we've heard Ling talk about, pivoting by discharge date allows us to see exactly when we're moving the needle on something. So we're going to be looking at it both ways. And if we go to the next slide, we can see some of the tactics that we're planning to implement. So we've heard Ling talk about commit to sit and CI care. In addition, we're looking, so there are customized discharge folders that are already on site and getting implemented. We're also going to be using Prescani's I rounds to focus in on physician shadowing, so offering coaching in real time. And then a few other kind of environmental things, right? Visual management to make sure that room cleaning is completed. And then again, using I rounds for cleanliness. We go to the next slide, please. This is our last measure that we've historically reported. This is our diabetes control, so our population of patients with A1Cs greater than 9%. We see that continued positive trend in the right direction. So lower is better. Again, this is an inverse metric, and they continue to improve, which is wonderful. If we go to the next slide, we'll show the action plan for our HEDIS team. So we're going to move that metric to more of a sustainment metric. They've had great success there, and they're going to cast a wider net now. They have been focusing on combo 3. We haven't really talked about that extensively at this group, but they are, in addition to that, going to expand their focus to cervical cancer and breast cancer screenings, as well as chronic disease management in the form of the blood pressure control metric. And then their last metric that they're adding in is going to look at access. So the percentage of patients where they're shooting for 86% of patients greater than 20 or older who have at least one visit with our ambulatory team. I think that takes us to our data slide. As I would be happy to entertain any questions. Okay, thank you.
Thank you for that presentation. It's an interesting kind of restructure. So we'll look forward to watching kind of this ongoing reporting. Next up, we have a regulatory and accreditation updates. We have a new Director of Quality, Regulatory and Affairs and Accreditation, Cynthia Fish. So welcome to the
Thank you.
organization, and we look forward to your updates.
Thank you. I appreciate it. Thank you for having me this morning. So I just wanted to give an update where we are today for the system regarding regulatory. So at Provident, we are still expecting our CAP, which is our lab survey, this year in 2023. The Joint Commission, we did hold a mock survey that was in January. So those findings and the corrective actions are reported out weekly at a regulatory meeting held at Provident. So that is going well. At Stroger, we did have a stroke recertification survey that was in February. There were 3 findings, all related to documentation issues. But on the flip side, there were some best practices that were identified from the surveyor. So kudos on that. And then in addition, we are planning to have a mock survey held here at Stroger this spring. So more to come on that. Thank you.
Thank you. I don't see any questions. We're going to move on then to item 4 on our agenda, action items, and we will take a combined motion at the end of these reports. We have no approval for appointments and reappointments for today. We're going to move on to Dr. Akintoran, who's going to present the Stroger Hospital medical staff action items for our consideration. Dr. Akintoran?
Yes, good morning, Dr. Kim.
Good morning.
Yes, okay, so I'm presenting the report of our credentials committee as presented to the EMS and approved. I'm bringing them before you for your consideration. These are the medical staff appointments, reappointments, and changes. And you do have that document before you. If there's any questions, I will just pause for a moment. Okay, thank you. So then I'll go to the summary of the HQPS minutes for the meeting of January, and just a few highlights there. For laboratory services, we have the proficiency testing on flow cytometry was 100% for 2022, which was great. For year 2022 also, 100% of all abnormal body fluid cytology slides were reviewed by the pathologists and completed by the pathologists compared to 99% in 2021. So those two remain very, very high and satisfactory. And then radiology, the fourth quarter of 2022, ultrasound turnaround time for start orders was 3.5 hours, which was compared to the to 8 hours that we had before, which was a great improvement. Our MRI inpatient case volume for the fourth quarter of 2022 was the highest for the year at 814. So we bounced back, very well from the downturn from COVID. Clinical documentation, the surgical case mix index for October 2022 was 3.05. Now, the data that was presented by Dr. Mikaitis is much recent, right? So we see that the improvement in that. So for the October 2022, the 3.05 was above the baseline and better than the similar hospitals. Overall case mix index was 1.73 for the third quarter of 2022 that was reported at that meeting of January. That number was slightly higher, slightly better than similar hospitals. There were no action items arising from this for the EMS committee, and there are no action items being presented to you today. Thank you. If there are any questions, I would take them. Thank you.
Hand raised. Thank you so much for that report. I'm going to turn it over to now Dr. Loafman, who's going to present the Provident Hospital medical staff action items on behalf of Dr. Kirby. Dr. Loafman?
Yes, thank you. Good morning, directors and colleagues. So the action items from the QPS, the most recent January meeting that you have are here for your review. Some highlights, again, some very impressive performance in terms of environment of care. As we've mentioned before, the staff and leadership there are really engaged in trying to catch up and keep up with some of the opportunities for improvement that have been noticed in prior survey reviews. So that looks great, 100% on both of the measures there. Behavioral health efforts made to try to help take care of the chronic disease issues that have been associated with patients with serious persistent mental illness in terms of screening for comorbidities. And because we have an integrated system with integrated primary care, we're able to refer those patients for primary care. So it's another really positive output from the psych team trying to make sure that their patients are getting comprehensive care, not just psychiatry care. And then the lab, we have some highlights from the lab reporting critical values. Now again, with more 24/7 care going on in Providence with the expanded inpatient unit, higher ER volumes. We felt these were important parameters to be watching, and we're seeing a good success there in terms of timing for critical lab reports. And again, this is both inpatient, ER, and also covers outpatients who we're seeing in the primary care and specialty clinics there. And lastly, the blood culture contaminant rate, there will occasionally be one, and so less than 3% is the goal, and we were just there. There were no further actions. The credentialing committee report also was included, no outliers or exceptions there. So that completes the report in Providence.
Thank you. I don't see any questions, so thank you for your report. Appreciate it.
Happy to be here.
We're going to move on. The February 16th minutes were approved by the board at the February meeting. And we're just open if there's any corrections or changes that need to be made, this would be the time to make them. So I'm not seeing any discussion here. I'm going to entertain the following combined motion to approve the following. Approve item 4B, Stroger Hospital Medical Staff Appointments, Reappointments and Changes. Approve item 4B, Providence Hospital Medical Staff Appointments, Reappointments and Changes. And accept item 4C, the February 16th meeting minutes.
This is Director Garza. I'll make the motion. Second.
Great. So the combined motion has been made and seconded. Madam Secretary, can you please take the roll call vote on the combined motion?
Roll call vote on the combined motion. Aye or nay? Director Garza?
Aye.
Director Story?
Director Story is aye.
And Chair Kim?
Aye.
You have 3 yeas and 0 nays. And for the record, Ms. Merriweather joined us. I apologize. I should have said that earlier.
Great. Thank you. So the ayes have it and the combined motion carries. We're going to go into closed session. No action item is anticipated in open session after the closed meeting has adjourned. So I'd like to entertain a motion to go into a closed meeting pursuant to the following exceptions to the Open Meeting Act 5 ILCS 120-2C 1, 11, 12, and 17.
I'll make the motion. Second, Madam Chairman.
Great. The motion is made and seconded. Madam Secretary, please take the roll call vote on the motion.
Roll call vote on the motion to go into closed session. Aye or nay? Director Garza?
Aye.
Director Story?
Director Story is aye.
And Chair Kim?
Aye.
You have 3 yeas and 0 nays.
Great. The ayes have it and the motion carries. We'll now go into closed session.